And as I begin, I have no disclosures to report, no financial disclosures. And we're gonna kind of describe and understand the clinical importance and utility, kind of how the comorbidity of opioid use disorders and pain, and then kind of go into some management strategies around both acute and chronic pain. That's really what we want to do. And I'll begin directly by going into what is the prevalence, right? Like how common is the experience of pain in individuals with opioid use disorders? So I pulled together some studies here. If you look at these studies, one of the older studies, that one of the first really good quality studies to try to look at this, the Rosenblum study from 2003, basically said that about a third of people with opioid use disorders have comorbid chronic pain. But then you can see that some of the more recent studies, the two that came out in 2017, essentially said that about a half to two-thirds of individuals with chronic pain, or rather with opioid use disorders, also have chronic pain, right? And perhaps this, reflects kind of better understanding, better education about around the comorbidity of opioid use disorders and chronic pain, which, as our close colleague Joanna Katzman likes to say, are both epidemics, right? Just like opioid use disorder is an epidemic, she often likes to say that chronic pain is also an epidemic in the United States. And maybe this reflects better understanding, better education around it, or perhaps it reflects the fact that we've seen the opioid epidemic change, right? From sort of it essentially driven by heroin to prescription opioids, to back to heroin, and now to fentanyl. And perhaps some of these studies are picking up on, kind of the comorbidity between chronic pain and opioid use disorder that we really saw come to light in the early part of this century. So this one is going more into more detail with this study from 2017, which looks at, essentially what they did was they looked at everyone was admitted. This was out of UCLA, I believe. And everyone was admitted to their opioid use disorder clinic between 2006 and 2015, so over a 10-year period. And they admitted about 5,300 patients, over 5,000 patients. And what they found is that, again, two-thirds of them, roughly, had coexisting chronic pain at some point. And only about 35% had no history of chronic pain. And if you looked at the ones with opioid use disorder and chronic pain, this is kind of striking that for most people, right, who had both, it was the chronic pain that came first, followed by opioid use disorder. And out of the overall 5,000 patients, for about 40% of them, right, it was the pain that came first, and then the opioid use disorder developed. And the relationship was indeed bidirectional, but pain, it was more likely that the pain came first, that the chronic pain developed first, followed by the opioid use disorder. And those patients who had chronic pain first had higher rates of other mental disorders, other health conditions. But this patient, the 15%, or rather the 10% who had opioid use disorder develop first, they were essentially more likely to have other substance use disorders and more severe substance use disorders, right? As more likely to have HIV, hepatitis C, things like that. So very common. So the take-home point here being that when we're working with patients with opioid use disorders, we should be asking about and being on the lookout for chronic pain, and vice versa, because the two do often coexist. So now I'm gonna go right into acute pain management. And a little disclosure here over these slides that I've included 3 slides for reference, which are courtesy of PCSS, which is Providers Clinical Support System, that I know, Brandon, you're very involved with, and as is Eric Ketchum, one of our close colleagues. And I also do a lot of work with them. And 3 slides on acute pain management come directly from PCSS training course for emergency department physicians. And I really included them from reference. I won't go into them in too much detail here because it really would take a long time to go through them, but they are here for reference. And this is some public domain artwork by a person who chose to be identified, sharing their experience around pain, called Overwhelm. And I think it captures it well. So I'll begin with a vignette. This is actually something that I experienced when I was a fellow in addiction psychiatry, and it sort of stayed with me, this vignette. So AN was a 45-year-old female who just had a shoulder surgery. History of opioid use disorder, had been previously treated with methadone on 2 separate accounts. She stopped treatment both times and returned to using heroin when she stopped methadone. Did well on methadone. When she stopped it pretty quickly, as we often see, she went back to using heroin. And right before the surgery, she had been smoking about 0.5 gram of heroin 2 or 3 times a day. And now after the surgery, she's on morphine continuous infusion, 4.2 milligrams per hour. Plus, she can get a 10 milligram IV bolus for breakthrough pain every 4 hours. She last used it 2 hours ago, so she has 2 more hours to go, right before she can again get that additional pain management. But she's requesting more pain medication. She reports her pain is 9 out of 10. She's crying. Her vital signs are stable. And what I hear when I get to the unit as the consultant is she's drug seeking. She's already getting more pain meds than any other patient on the unit. She doesn't need more. Besides, she's an addict, and we don't want to worsen her addiction. Right? So let's keep this person in mind as we go through some of the acute pain management slides. Right? And remember, we're talking acute right now. We'll get to chronic later. And I clarify that because the principles of managing pain in patients with opioid use disorders are, I'd say, pretty dramatically different, depending on whether we're talking about chronic or acute pain. Here, we're focusing on acute pain. Some commonly held beliefs, according to literature. Acute pain in general is frequently undertreated, and likely even more so in patients who already have a history of substance use disorders, though there is no great literature that I'm able to find showing good estimates. But it's been sort of commented on that it's even more so in patients with a history of addictions, because addiction is seen often by healthcare professionals as primarily a social problem, right, as opposed to a health problem. And patients with substance use disorders are often seen as being manipulative by providers, right? And there's a big gulf. It's been shown that often providers are worried about manipulation, and patients are worried about their pain being undermanaged and being stigmatized, right? So there is a big gulf that we need to be aware of, and how do we help bridge that in an ethical and humane way? So this is the suggested approach, according to ASAM, it's the American Society of Addiction Psychiatry, so that we begin in the case of, certainly accepting the patient's self-reported pain, keeping in mind that pain behaviors vary widely, and vital signs by themselves are not very reliable indicators of pain intensity, right? And consider, as we decide what to do next, the concepts of addiction versus pseudo-addiction versus physiologic dependence. Physiologic dependence is simply what happens when someone takes a medication for a long time. Their bodies, their brains, their neurobiology gets used to that particular medication, right? And so when it's withdrawn, they may experience withdrawals. They may build up tolerance. That's physiologic dependence. Certainly happens with prescribed opioids or not prescribed opioids, but also happens with many other medications, right? Pseudo addiction is this concept that really came about in the 1980s in cancer literature, which is the idea that someone is displaying signs that at surface may seem like addiction because their pain is actually undertreated, right? And in that case, as their pain gets better treated, some of those behaviors, you might be seeing the compulsion, the irritability, the demands might actually go away, and their functioning might improve. Versus addiction, right, which is really a neurobiological illness, according to ASAM, where the person comes to see the substance as being necessary, not just for reward, but for survival. And one of the key things is that when someone has a true addiction, a substance use disorder, simply giving them more of the substance is not going to lead to improved functioning. In fact, you may see the opposite, where their functioning actually worsens as they receive more of that substance, as opposed to pseudo addiction, in which you would see the functioning improved. In general, it's recommended that in these acute pain cases, if required, do not withhold opioid analgesics from people with addictions or substance use disorders, right? Keep in mind that because they have the tolerance, they may actually need higher doses of opioids, and the risk of respiratory suppression may actually be lower in patients who are opioid tolerant. And remember, I get this a lot, that the patient's already on methadone maintenance treatment. Why do they need extra opioids? Remember that opioid agonist treatment is only treating the baseline substance use disorders, the baseline addiction, not the acute pain. So don't withhold it if required. At the same time, and these are the slides that are coming directly courtesy of PCSS. I know Dr. Warwick is really familiar with these next few slides as an ED physician who does a lot of these trainings. Is, of course, we don't want to start with opioids, right? Generally a good idea anyway. This is a really good algorithm that's here for reference, right? Always want to start in cases of acute pain with non-opioid treatment like NSAIDs, but also RICE, right? Rest, ice, immobilization, compression, elevation, and altos, the alternatives to opioids, which I know are thankfully being utilized more and more, including trigger point injections, local anesthetics, gabapentinoids, nerve blocks, hematoma blocks, etc. And even more advanced regional nerve blocks, which our physicians are, and clinicians are increasingly familiar with. Also things like, don't forget things like subdissociative ketamine or alpha-2 agonists, such as clonidine or dexmedetomidine, all of which can be helpful. So these are all of our altos, right? Alternatives to opioids. Now, if patients are already on MOUD or medications for opioid use disorders, what do? Remember, they have that higher opioid tolerance. If they're on naltrexone, which we'll get to in a minute, the acute pain is going to be very difficult to treat with opioids because naltrexone is blocking up those mu opioid receptors. So we're going to need to really maximize those altos to get that extra bit of analgesia. Buprenorphine also has a high binding affinity for the mu opioid recipe. So again, you're going to need to maximize those non-opioid modalities. Methadone is a long half-life full mu agonist. So there, the strategy differs, which I'll go into here in a minute. Right? So these are some of the things. So remember, even in case of acute pain in an acute care setting, we're going to start with non-opioids, if at all possible. But there are a few things you're going to do. So what are they? Let's go into it. So for patients who are already on medications for opioid use disorder, let's start with methadone, right? So a patient comes into the emergency department, they tell you they're receiving methadone. They're dosing as an opioid treatment program. So you can continue the methadone after verifying the dose from the home clinic. So all patients with opioid use disorder who are on methadone will have a quote unquote a home clinic or an opioid treatment program that they go to. And if they're able to give consent, if they're verbal, they likely will tell you where it is because they want to make sure that they receive their methadone so they don't experience the withdrawals. So once you have the consent, you can call up the clinic, verify the dose, and you may continue it, right? If the dose cannot be verified, say it's Friday evening or Saturday morning and the clinic is closed, it's safer to break up the self-reported dose in 3 or 4 times a day dosing, rather than giving it all at once, right? Less risk of one-time toxicity and may even be better for actually pain management to break it up. So it may serve a couple of purposes. So that's really a recommendation if the dose cannot be verified. Even if it can be verified, it's worth considering. If the acute pain is severe enough, should we be breaking up that methadone dose? I think it's a reasonable strategy. And on top of it, you can break in addition to all those non-opioid modalities, if needed, you can add in short-acting opioids for breakthrough pain. You could gradually increase methadone dose, but I really recommend against it. Because if you want, if at all possible, I think this strategy of adding in short-acting opioids is probably a better strategy than going up on the methadone dose. Because if you increase the methadone dose before sending the patient back to the opioid treatment program, you're likely going to have to go back down to the methadone dose, right? And reconsolidate it. That opioid treatment program may not feel comfortable picking up the patient on that higher dose. So often this strategy, the first strategy, winds up being more practical from a patient care standpoint. You don't want to administer buprenorphine, of course, if they're on methadone, because that will throw them into withdrawals. They can't take their oral dosage. IV methadone is, of course, an option, but remember the dosage is vastly different, right? You don't want to give them their PO dose in an IV modality because that can be very dangerous. So I've listed the general recommendation, of the IV conversion, so that's generally the idea with methadone. What if patients are on buprenorphine and now they have acute pain? Again, start with all those non-opioid modalities. That's always the starting point. And then the next thing we want to do is adjust that buprenorphine dosing interval. We certainly want to split it up, and we may want to consider going higher on it. So what do I mean by that? So I'll give an example. I had a patient, I think this happened about last year, I want to say, who was very stable on Suboxone 12 milligrams daily for her opioid use disorder and had an acute pain generator. It was severe enough where, just acetaminophen, ibuprofen were not cutting it. So what we did is that instead of her 12 milligrams daily, we temporarily changed the dosing to 4 milligrams 4 times a day. So I went up on it by about a third, and I split it up from once a day to 4 times a day. And on top of it, she took acetaminophen. And that controlled the pain really well. And once that acute pain generator was resolved, we went back to our usual dose of buprenorphine. And that worked really well, right? So that's generally what we're going to do. If the pain is severe enough, and this also applies to patients on buprenorphine who are in an acute care setting where these things just don't work. Remember, we have short-acting opioids with high mu receptor binding affinity that will provide additional analgesia, even in a patient who's on buprenorphine. And namely, that is fentanyl, which is, right? I mean, I know we're in the midst of a illicit fentanyl epidemic, but in trained hands, it's a great ally. It's very accurately titrable, it's very short-acting, and can really get people the analgesia they need. And Dilaudid is another one that's often used. And certainly consult an addiction medicine expert if at all needed, right? Perioperatively, if someone is on buprenorphine, they're going to have a surgery. Again, this pre-op stuff is critical. I tell my patients ahead of time that if you're going to have a procedure, no matter how minor, let me know so we can make sure we can start that conversation and make sure our pain's going to be adequately and safely treated. As soon as the patient tells me that they're going to have a procedure, we're going to get consents, call up the surgeon, the anesthesiologist, the primary care provider, and start to come up with a treatment plan. How severe is this surgery? How much pain do you anticipate? What is your experience with buprenorphine? What help can we provide? Are you open to recommendations from me as an addictions expert, right? So generally what's done? So historically, the idea was that 3 days, sometimes a week before the surgery, the buprenorphine would be stopped. So the patient would go into withdrawals, and then they would go into the surgery, and the perioperative pain would be managed using full mu agonist. Then those would be tapered off, and the patient would be restarted on buprenorphine. Certainly works from a pain management standpoint, but there is a risk, right, of the patient being lost to care, or that recurrence of use happening. So we have gradually moved away from that, where really the idea is that, we don't routinely discontinue buprenorphine before surgery. That very often the buprenorphine is maintained. It's on board, it's maintained, and then perioperative pain is really managed using those alternatives to opioids. And if needed, if additional opioids are needed, then using fentanyl or Dilaudid, right? And then post-operatively, as those other opioids are withdrawn, the buprenorphine dose is maximized, split up into 4 times a day dosing until the pain resolved and the buprenorphine dose is reconsolidated. So very often, that's what we're doing. And this was really the first editorial from Anna Lamke out of Stanford University back in 2018 that made this case. And since then, this has become increasingly accepted in the medical field, right? Finally, naltrexone, as I mentioned, naltrexone is going to be providing that very strong blockade of the mu opioid receptors. So we're going to have to be really cautious about what we're going to do. So what I generally tell people is that for planned surgery, if they're taking oral naltrexone, the last dose should be 3 days before the surgery. If they're on the long-acting naltrexone injection, which is what many of our patients are on, the last injection should be 4 weeks prior to the surgery. And in case of an acute emergency or severe pain, it really is going to be those alternatives to opioids that we rely on. I've got a few reference slides here, including all those other non-opioid medications that can be used for analgesia. And as you can see, there are many of them, and these are really there for reference, right? And the idea of multimodal pain management We go into this in a lot more detail. Every year I do a course for our anesthesia residents, and we go into this in a lot more detail. But here I'm just including it for reference. Now we're gonna go into chronic pain management. And again, I'm stretching this presentation out a bit. So I wanna quickly check the chat to make sure there is no case. Let's see, okay. And okay, so great. So no case has been received. Wonderful. So I'll go into chronic pain management here. And this is another public domain art from someone suffering from chronic pain. And I think it's just incredibly poignant. So I included it. So here, the approach is very different compared to the approach for patients with acute pain. Some basic consideration. The history of opioid use disorder is the single biggest predictor of aberrant behaviors to prescribed opioids. So having a history of opioid use disorder doesn't mean we don't use opioids if they're indicated, but really should give us pause and consider those risk benefits. Consider consulting a pain management specialist, use a multidisciplinary team approach, right? And use non-opioid and adjuvant medications first. So really want to use multidisciplinary approach, maximize all of our non-opioid medications, maximize all of our non-pharmacologic therapies, such as CBT for pain, acceptance and commitment therapy, physical therapy, traditional healing, acupuncture, all of those things before turning to opioids. And if we are going to use opioids in patients who already have a history of opioid use disorder, we really have to do our due diligence. There's actually a separate talk we do, not every cycle, but usually once every few months, that goes into the evidence-based components of what that responsible opioid prescribing looks like. It's essentially being aware ahead of time of individual risk factors, using screening tools, although some of the newer evidence really points against a lot of utility of these screening tools. Before we used to really hammer that home, but some of the newer data has been more ambivalent about it. And ongoing monitoring, right? Close monitoring, and of course, naloxone co-prescribing. So I'm gonna quickly use a vignette here. So this was a patient from our clinic, 55-year-old female, came in for treatment of addictions. She had a 12-year history of chronic pain following an ATV accident and a pelvic fracture. And over time, she has increased of doses of opioids, and she was now taking 300 morphine milligram equivalents daily. And they were aberrant behaviors. She was buying them off the street. She would run out early. She would turn to multiple doctors. And now she was starting to report problems in marriage, work, relationships. She was depressed. She was anxious. And her quote was, "I have pain all over, and it's worse than ever." So we really diagnosed her with a few things: chronic pain, certainly, opioid use disorder at this point. And also, she likely had a component of opioid-induced hyperalgesia, right? I often, my alarms go off when I hear this, my pain is everywhere, things that used to not hurt are hurting, or something along those lines. So we put her on buprenorphine. We essentially switched her from all of her opioids to buprenorphine at a pretty reasonable dose, 4 milligrams 3 times a day, at which she actually did really well, had improvements in pain. She was happier, functioning better at work. I have my life back. And at this point, she's no longer in our clinic. She did so well that, she was able to step down to her primary care doctor, who's continuing to manage her with the same dose of buprenorphine last I had heard anyway. So keep in mind that for many patients who have chronic pain and opioid use disorder, think about buprenorphine. With split dosing can really help both. The little study that I had pulled up came out pretty recently in the journal Pain, which really took patients on multiple opioids, converted them to buprenorphine. These were patients with a history of opioid use disorder and chronic pain, and found that on buprenorphine, patient had less self-reported pain, higher pain threshold, so they were able to tolerate pain better, decreased pain interference, and improved quality of life. And that's very similar, actually, to this older study, which did a similar thing, where it took patients on multiple opioids, converted them to buprenorphine monotherapy, and looked at sort of the pain on a 1 to 10 visual analog score. The higher the number, the more the pain they're experiencing. And for all the patients, right, at all the morphine milligram equivalents, including the highest ones, when they were switched to buprenorphine, the red bar is buprenorphine, the blue bar is the multiple opioids they were on before, there were significant reductions in their pain experience, including for people who were on over 1,000 morphine milligram equivalents a day. And certainly buprenorphine was a lot safer. So in general, for most patients with opioid use disorder and chronic pain, buprenorphine is a good treatment option. So again, it tends to work for most people, but there is a subset of patients, according to some recent research, who don't benefit from buprenorphine in terms of their pain experience. And interestingly, the biggest predictor of someone, or I guess a mediator of whether or not someone's pain is going to get better with buprenorphine, is whether they have severe untreated depression. So having that untreated depression makes it less likely that buprenorphine is going to improve the patient's pain experience. So again, I think to me that's fascinating, right? Speaks to the psychological factors that impact the pain experience and the importance of treating them, addressing them in that whole patient point of view, right? So often buprenorphine works. There is also the buprenorphine patch and also a buccal form that are approved for treatment of chronic pain. So for most patients, think about buprenorphine. But for a small subset of people, the pain is so severe that methadone may be needed because buprenorphine is simply not going to treat their chronic pain. So what do I mean by that? And again, this is a vignette based on a patient with identifying details change that we treated several years ago. The 64-year-old patient went into the emergency department with dysuria and wound up getting diagnosed with advanced cervical carcinoma. And we coordinated, she had a long history of opioid use disorder. And we coordinated with the palliative team, the oncology team, and they said that her pain is going to be so great because of the illness and also as a result of some of the treatments that buprenorphine is not going to cut it. So we essentially put her on methadone through our opioid treatment program and very carefully titrated up. Meanwhile, the palliative care team prescribed her short-acting opioids for breakthrough pain. And we talked regularly. I mean, we talked every couple of weeks for close collaboration, and patient did very well. She passed away several years, about a few years later, but she did really well. And she said her pain was controlled and she felt like she was treated with dignity, which of course is important, right? And finally, naltrexone, probably best avoided in patients with chronic pain because it's going to take away a lot of the treatment options. Got some references here. I will stop it